Hello everyone. Those of you watching the video, this is the order we're going to go through. Pneumonia, asthma, lung cancer, PE, then ABG. All right. So there will be a few back and forward with your slides. I will wait for you because sometimes you do have to write some stuff. So if I'm going too fast, let me know. We're going to over. Okay, so before I tell you about respiratory, obviously I went over it myself to teach you this. So I would tell you, respiratory is not something like heart. You don't need much explanation. What do you need to do is memorization. You can't memorize whole of rest because you've got obs and gynae, you have everything. So I'm going to narrow it down for you and tell you this. Memorize that, learn this, learn that. Exam topic, exam bits. Because there's no time to explain a lot of stuff. It's time to memorize for the exam. And like I said before in introduction video, I want you to, whenever you see a question, and then you read the last line, initial diagnosis, whatever, and then you read your options, you should have the answer 50% already. Because you've done so many questions. You're reading the question just to verify your answer, then going on quickly. So you need to be very fast, very slick. So respiratory is one of those topics you can be very fast. There's key points. So some topics you have to know, some of the subtopics you have to know management, some of them you have to know investigation, some of them you have to know diagnosis. Remember, they either want you to diagnose the correct one, or they want you to know the investigation, or they want you to manage it. For each of them, I'll tell you which ones you need to know. Obviously, do other questions to find out if that's the case, yeah? All right, so I'm starting off with pneumonia. So chest infection, just chest infection, isn't it? So pneumonia is when you have a consolidation in your lungs. You can have a LRTI, lower respiratory tract infection, but whenever you have a consolidation, that's a pneumonia. So normally symptoms is productive cough, you have fever, shortness of breath, pleuritic chest pain. The moment when they see pleuritic chest pain, do rule out other things like PE. Because here in London, in NHS, we care about PE a lot. So anything, pleuritic chest pain, I know it's in pneumonia as well, because obviously you have consolidation, you are pushing against the nerve, so you have pleuritic chest pain, but do rule out PE. Just have a quick look if you see pleuritic chest pain. X-ray will show consolidation. Obviously there will be water liquid, so that's consolidation. Investigation. Now obviously in exam for pneumonia, they're going to ask you specific pneumonia. This is just a title, all right? So we're going to go into specifics soon. Now, this is another exam type question that you can get, community-acquired pneumonia. All you have to know is the curve 65. Learn that. So what is that curve 65? Anyone who comes into an A&E admission, you do curve 65 to find out if we need to treat this patient in hospital or they can go home. Yeah, it's very simple. Now, 0, if they score 0, then they can go home and get antibiotics oral. Or if you're getting an increased score of 1 or 2, consider hospital referral. And then obviously if it's 3 or more, then hospital admission. Now, exam thing. If you see someone with 92%, below 92% oxygen saturation, don't worry about curve score, admission. Okay? So pneumonia is something obviously we know they can go home with antibiotic. So this is just to determine if they should go home or stay in the hospital. Remember, 92% curve score, 0 low risk, 1 or 2 increased risk for consider hospital referral, and 3 or more hospital admission. That's it. Okay? So don't spend time in this pages, try to memorize, move on fast. Yeah? Next page. It's pneumococcal pneumonia. Obviously, they want you to know all the bacteria, which one's most common, which one's where, if you're alcoholics, so this one is the most common cause. Okay, so this is the most common. If you run out of option, there you go. So we have pneumococcal pneumonia. I'll tell you more. Now, obviously, in England, it's common in winter. So read the history quickly. Just you're skim it. So if you're seeing common in winter, you have viral infection before that. So they will tell you they had runny nose and everything, and then they will come with a chest infection, or they can have vesicles in the mouth. So that will viral, and then they come and tell you they have fever. Then that should go straight away. The first one, strep pneumo. Otherwise, they tell you in the exam, oh, HIV positive, or they will tell you alcoholic. That will divert you somewhere else, okay? So simple background with a chest infection, previously any viral infection, go to strep pneumo, yeah? Straightforward. Okay, now in here, obviously the treatment is amoxicillin, and yeah, That's it. Moving on. Hospital-acquired pneumonia. I just want you to learn the definition. What do you mean by hospital-acquired pneumonia? You stayed in hospital for 48 hours, then you have a chest infection. After 48 hours, that's hospital-acquired pneumonia. All right? Now, next one is atypical pneumonia. What makes it typical, what makes it atypical? Obviously, a lot of us know it's a dry cough. Okay, so if someone's patient will come in with a dry cough, and then you're going to see a history, then obviously you're going to think of atypical pneumonia. And now, for atypical pneumonia, guys, we need to find the diagnosis. Find the diagnosis, that's the key point. Now, the first one we're going to do is Legionella. And you know, if you've done a lot of questions, Legionella is very, very common. Now, everyone knows Legionella is a travel history you need to look for. Spain comes up in exam, air condition comes up in exam, anywhere that is cold that it comes up in exam. So travel abroad for business purposes, that should be your in your head. Next one, flu-like symptoms including fever. Next one is confusion. Okay, you know, in your the lecture notes you have, the few things I'll tell you, just highlight those. Because if you highlight everything, when you're revising, oh, I'm memorizing everything again. What's the point? So just do note and anything that is very, very important. So you know to skim read it just before the exam. All right? Anyway, so confusion, low sodium, highlight that. So that's important. So confusion, low sodium, cough is dry initially and it becomes productive. Now, this is important because 50% of the patient becomes productive. If you see productive cough, do not rule out Legionella straight away. Okay, look at the question, look at the background first. Okay. Now, chest X-ray. Chest X-ray in chest infection is very important for few diagnoses. In this one, Legionella is important, but there are other history they will give you, and they will give you low sodium to direct you to Legionella. The purpose of the exam not to confuse them, make it so hard. They will give you enough hints. You need to be smart enough to pick them up. Okay. Diagnosis important, urinary antigen. Okay, we've done enough questions on Legionella. We know about it. X-ray, unilateral lobar or multilobar shadowing. Again, shadowing you can find in others. In here, they will give you enough history. Young man, young male, dry cough, visitor Spain, business trips. They will give you enough information to direct to Legionella. All right? Moving on. So Legionella it was more of your diagnosis, and obviously also the treatment is erythromycin. Remember that. Okay, mycoplasma pneumonia. Okay, so that's again just going to give you dry cough. Obviously, we talk about atypical pneumonias here. That's going to give you dry cough. What is the history they're going to give you in this? They will tell you military person, boarding school, prison. Okay, mycoplasma pneumonia, flu-like symptoms before that. Again, lots of all of this we're going to do has flu-like symptoms before, then they have a chest infection. Don't use that as a differential, right? Because it's going to be hard for you guys. So flu-like symptoms, there's other condition you get flu-like symptoms. This will be more gradual, okay? So it won't be like, oh, flu-like symptoms and next day you have chest infection. It's a more gradual one, this one. Patient will have influenza-like illness, then they will get the mycoplasma pneumonia. Now, how do we differentiate it? There's lots of words in here. How do you differentiate it? It's the X-ray here. If you've done enough questions, you will see bilateral consolidation will be in mycoplasma pneumonia. Yeah, and you will see the history of military, boarding school, prison. Those things will be your differential from others. Okay, so make sure you write that down. And investigation will be mycoplasma serology, and treatment will be erythromycin. Again, this one is more of diagnosis for you to diagnose the correct one. Okay? So look at the history again and your X-ray for this one. Next one is your, what's next? Pneumocystis. Okay, so this one as well, again, we find it very easy because it's associated with HIV. Any HIV patients coming with dry cough, this one should be number one. HIV patient, dry cough. Look, in the question, in real exam, we won't have time. When we're reading a question, HIV dry cough, going straight to the answer, pick it. All right? So all patients with CD4 count less than 200 should receive a PCP prophylaxis. That's another vital information. Some of the information you just have to learn it, memorize it, like this one. Obviously, features are dry cough, fever, very few chest infection. Other signs are HIV. So they might not say to you their patient has HIV. They might say, oh, it's oral thrush or weight loss. So, and you, from the history, you need to direct yourself to again pneumocystis jirovecii. So look at the Carini with HIV symptoms, oral thrush. They're going to get weight loss, CD4 count. Mention any of these with a dry cough, then go to that. Treatment is clindamycin. Another vital information I'm going to give you, write that down. X-ray, bilateral interstitial shadowing. Okay? So in here, X-ray is important. Remember, a chest infection, X-ray is important. Okay? So you see, when you do a lot of questions, look at the X-ray for mycoplasma pneumonia, for these ones. So they will give you a clue straight away. Even forget the history, X-ray is important. With a little bit of history, you can go to the diagnosis. Yeah. So next one, there's a big picture for you to remind you of the birds. Okay, so again, what will be in the history? The history will be given anything related to the bird. Look for the question, dry cough, look for the birds. They might not even say the word bird. They might not even say the word pigeons. What will be there? Sometimes I've seen questions, it will be walking under the bridge, working in few of the places where the birds are mentioned. So look for these ones again to pick the right bacteria, go for it. Okay, so but I will give you some of the, so in here, diagnosis is important and the treatment is doxycycline. Okay, that's another piece of information you need to write. So write that big, doxycycline. Because most of us get this diagnosis right, but just the treatment is the problem. Okay, another piece of information actually in here, I've seen questions with organomegaly. Yeah, read the question again. You see organomegaly. Why these small things are important? Because sometimes they will miss out stuff and they will just put organomegaly on its own. Or previously, mycoplasma pneumonia. So they will give one or small information. So it's good to know all the basic the key points. So in here, organomegaly is there as well as one of those. Okay. So any contact with bird, yeah? Okay, so we on the extra stuff now. I don't know if you have the page open. This is the page, extra stuff. Okay, this page will be explained later on anyway, so I'll just wait for that. So with the word swinging fever, it should remind you of abscess. Swinging fever. Lung abscess, it should give you swinging fever. Okay, so these key terms will make your diagnosis much easier. So I'm giving you those. And there's some points I'm going to tell you later, so there's no point telling you now. Okay. Okay. Now, when we're doing respiratory questions, anyone with smoking history, think of cancer already before even reading the answer. Think of COPD already before you read the answer. Okay, they're not putting smoking history for no reason. Everything in question is for a reason. All right, and there are a few lines they're making the question longer now. Why? They're trying to divert you. Don't get diverted. Pick up the real things, because if you're smoking, you will go one direction. Okay, so if patient with a smoking history, assume COPD, assume lung cancer otherwise. Then you read the question, it will make it much easier. So you want to train your eyes, guys, yeah? Old patient with CO2, okay, now, that's fine. And here, obviously, I'm going to give you more information. This is another typical exam. Anyone with alcoholic Klebsiella, that should be in your prime diagnosis. All right. Next one, aspiration pneumonia. Aspiration pneumonia is very common in England. Alcohol is a big in here. So I will spend time here, aspiration pneumonia. People need to understand aspiration pneumonia, okay? People only think of alcoholic. No, if you have swallowing difficulty, aspiration pneumonia. If you gone for a surgery and in a recovery, they will say anything, okay? It's just you understand you have to understand the situation. For example, someone's gone for a surgery, come back, they're in a recovery. Obviously, they have anesthesia. Their swallowing is not very good. So if someone's having a chest infection, so when you're reading literally the first line, I've seen question, first line recovery, cough, fever, you think of aspiration pneumonia straight away. So this is just an example, guys, recovery. Yeah? So you can think of anything that will give you swallowing difficulties, drunk, anything that gives you, anything that you can aspirate, think of aspiration pneumonia. Impaired, look, so there are a few here. Poor dental hygiene, swallowing difficulties, prolonged hospitalization. So all of these, they all go back to the same thing, that this patient will have problem with swallowing, so they will aspirate something, gone into the lung, have chest infection, okay? Now the bacteria that is common is strep pneumo, is common. Those bacteria here in the board, when you see those bacteria, it should say something about them. Like when you say strep pneumo, what did I say at the beginning? Most common, isn't it? When you see Staph aureus, what should it remind you of? IV, skin. So, exactly. So every hemophilus influenza, COPD, that's it. See, when you see, this is Plab. When you see one word, it should give you the whole history, boom. Hemophilus influenza should give you COPD. Pseudomonas aeruginosa, you should give you, I'll tell you, then you'll know it. Now no one's talking about it. Bronchiectasis, okay? Okay, so this is the chest infection, okay? We've done with the chest infection. Guys, do more practice questions to get your eyes trained. And look, we went through atypicals and typicals. Typicals are very easy, productive cough out. Atypical, look for, there's only a few for you to worry about. Don't get these rest questions wrong because they're very easy. All you have to know is get them right. Remember, X-ray for a couple of them very important. Mycoplasma pneumonia, and there was another one, if you remember. What was it? Exactly. So those two are very important for X-rays. So some are X-rays important, and some are like look for the history is important there. Asthma, everyone finds it confusing. I don't know why. So let's go over it. Okay. I did make a video and put it up for asthma management. Okay. Now, asthma, guys, there are risk factors. This is for reading purposes. If someone has asthma in your question, you will know asthma straight away. Okay. Get the asthma page open. Yep, everyone got asthma? No? Yeah? Okay. Yep, got it. So asthma, there's obviously risk factors. That's for you to read. Clinical features, you have wheeze, you have cough, is a sputum or not, it doesn't matter. If you have asthmatic patient, in your question, you see the patient is asthmatic, wheezy, short of breath, chest tightness, that's asthma. Investigation, memorize that. What's the definitive, they ask you spirometry, that's something that should be highlighted and should be well known by now. Peak flow, very important, peak flow. People get this peak flow question wrong. Why? Asthma, for peak flow, it's for monitoring purposes. All right? So if they talk about monitoring asthma, so go straight to peak flow in your answer. All right? You just have a quick read, go straight to. If it's definitive, spirometry. That's it. So in the whole page, these two are the main point. Now, obviously the treatment, we are going to be treating the patient if it's acute or chronic, or if it's, now, the first one is acute, okay? So a patient comes in, desaturating, wheezy, what are you going to give? So, yeah. So the mnemonic I use is ONPMA. I don't know if you guys use the same one. So ONPMA, I still use it because I'm in A&E, so it's very useful. Oxygen, nebulized salbutamol, Pred, 40 milligram. You don't have to know the dose, but I'm just saying 40, magnesium. And then these two, they don't want you to learn. They want you to learn these two. Oxygen, nebulized salbutamol, Pred. Okay, acute. Aminophylline, magnesium, that is there for the question. Oh, do you want to see it? Oh, okay. So it's there. Oxygen, salbutamol, nebulized salbutamol, and P, Pred, magnesium, aminophylline. Now, obviously, see, you say you have nebulized there, inhale there, Pred there, IV there. That will obviously depends on the question that you're reading. If someone's really bad, you want to go for IV. If it's something like tolerating, you want to go for oral. Yeah? So that's not something to avoid debate over Facebook or if it's oral or IV. Depends on the question.
They say two things in the questions, go for the third step.
Yeah.
This is the simple thing.
It's
Just 5 steps in order. If they give 3 steps, go for the 4.
Exactly. So ONPMA, if you memorize that for acute, that's done. Oxygen, nebulized salbutamol, PRED, magnesium, aminophylline. Okay? Now, chronic is the problem, isn't it, that most people have. Now, I'm going to see if I can make it quite easy for you guys. Remember, for asthma, peak flow, guys, monitoring purposes, yeah? Just to say that again. Now, chronic, okay? I've made a video, so maybe you can do a small diagram, or let me see if I can do a small diagram. So, from today, after today, you're not going to be worried about asthma. Let's finish this. So, oh, okay. Do you want me to move? But I think it's the camera, isn't it? Okay, can you see now?
So you can write down this.
They can't see, that's why. Okay, can you see? Yeah. Okay, good. Is that right? Okay, cool. So, asthma chronic, yeah? First thing first is the 3 things that you need to know. SABA. If you're using SABA 3 or more time, you need to go to ICS. Remember that. 3 or more times. If someone is symptomatic, 3 or more times. So remember, 3, 3, 1. 3 times SABA, 3 times symptomatic per week, in a week, and 1, what's 1? Waking up once in a whole week because of the shortness of breath. Okay? That's the first thing I'm telling you about asthma chronic. Okay? 3, 3, 1. Once they hit these points, then now let's start talking about asthma chronic pathway. Okay? Now, the first thing, obviously, we're going to give them SABA. Okay? Now, next one is low dose ICS. Okay? Straight away, you go to low dose ICS. You have a small threshold for that. So remember, and the threshold is this. So once someone ticks this, you go to low dose ICS. Very easy. It's not hard, difficult to memorize as well. Now, patient comes back to you again from GP. Patient comes back to you again, oh, doctor, low dose ICS is not working. What are you going to do? You're going to add LABA, SABA, LABA. Not hard yet. So you're going to add LABA. Patient goes home, comes back to you again. Oh, now this is where people make mistake. So LABA, they go home and they say LABA is not working. You come back. So as a GP, what are you going to do? If LABA is not working, stop LABA. Increase the ICS. That's why I said low dose ICS. If you memorize a low dose ICS, then you remember to go higher later. If you think of ICS, then your brain, it's easier for the brain to memorize it. Low dose ICS, then you know later on I need to increase that. Okay? Easy. So if LABA is not working, stop LABA, increase ICS. What if patient comes back to you again and says, LABA is working, but it's not as good. Still, I still have problem. So keep LABA, listen to the patient, keep LABA, increase ICS. Can you see? Depends on what they're saying in the exam. If they're saying LABA is working, but it's not still adequate, I'm still having shortness of breath, I'm still having all this problem, okay, fine. You listen to the patient, you're increasing the ICS. Can you see? You're increasing ICS no matter what. Now, third step is if LABA is not if the patient comes back to you and say, oh, there's benefit from LABA, but it's still not working, then you're keeping LABA, but you're adding another drug. Okay, another medication. And obviously in here, you can see here, LTRA, theophylline, LAMA, just don't worry. Because in London, we care about, there's one drug they're going to say in a name, Montelukast. Okay, normally that's what they're going to say in exam. Montelukast, you add that. So can you see, after adding LABA, if still not working, you stop it. If LABA is not working, increase ICS. If it's working, still not is inadequate, so then you're keeping the LABA, you're increasing the ICS. If you need to add a medication, it will be next is Montelukast.
So next is with LABA, ICS and Montelukast.
LABA, ICS, yeah, LABA, ICS, Montelukast. Can you see? Now, another way to memorize this, This is step 1, 1 medication. Step 2, 2 medication. Step 3, 3 medication. Yeah, I said that in the video to make you understand. 1, 2, 3. So you're not getting lost. And this is where they're going to examine you guys, in these 2 steps. They don't want you to be a respiratory consultant here, because next step soon is the referral to respiratory. They don't want you. They want you to learn here, GP, SHO stuff here. So when to add SABA, when to add low dose ICS, these 3, 3, 1, and then LABA. That's it. Next step now is refer. If all of done, everything you've done here, next step is refer to respiratory consultant or respiratory chest physicians and everything else. Can you see? If you try to take in too much information, that's where you're going to go down. Learn less, stick to it. Okay, so the next step anyway, I'll just tell you, is considering the trial of, so next step, if it comes up in exam, otherwise you're going to tell me, oh, shit. So next one is LABA, so you can add any of those medication next, which is mentioned in your thing, any of those. You can add any of those. So 4th step, 4th medication. And the reason I'm not going to go over it, because I don't want you to focus here. Just stay there. And the 5th, and add the 5th one. 4th one, add the 4th one. 5th one, add the 5th one. But at this step, you're going to refer it to outpatient. So remember, after 3 steps, your referral. 4th drug. 5th is high dose of steroids anyway. Okay? But exam from there to there. Is that clear? And remember, acute ONPMA. That's it. Asthma's done. Finished. So don't waste time going home. Do stuff like gynecology, where it's harder to memorize. So the asthma's finished. Remember 3-3-1, yeah? And after 3-3-3-1, and after 3 stops, referral. Okay, there's another page in your, I don't have it in mind, is exercise-induced asthma. Can you open that? They ask you a question on that. So I wanted to make it clear. And again, there's a lot of debate on Facebook of exercise-induced asthma. So I'll make it clear for you guys. Okay, if it's open. Exercise-induced asthma, everything is written there. We've written it because we had to write something. But cancel everything. I'll tell you what you have to know for exam. SABA is the answer. Exercise-induced asthma, SABA. Now, second thing, why there is a debate, because I've read some of the comments, but I'll never reply. Some of them are correct because they're respiratory physician. I know them. Now, exercise-induced asthma, me and Imran, we did a lot of research behind it because we wasn't sure. Because our research, it has to be strictly based on GMC guideline. Exercise-induced asthma, let me give you the definition for it. Poorly controlled asthma is exercise-induced asthma. Exercise-induced or whatever induced is asthma. So you're using SABA before exercise. If they're asking question after SABA, is this. Don't argue with anyone. Yeah.
But what happened to sodium chromate?
Out.
Yeah, this every time the question.
Exactly. So that's old spec.
Sorry?
That's old. It's been changed.
Now it's changed. Okay.
SABA is the answer. And then if SABA is not happy with it, go through this. If you're confused, I'll give you a best thing. Go to Google, just write Plab 1 demonstration question from GMC website. And guess what? GMC website has an asthma-induced question. And just read the answer. And it's coming from GMC, straight away. So you don't have to go Facebook to argue with people. Just go there, GMC website, and it's there. Me and Imran, when we found that, we didn't do any further looking. That's it. So it's poorly managed asthma, before exercise, SABA, and then all of that. I did write, you see, the notes was written by me. I did write sodium, and I did write before 30, 40 minutes before that. Depends when to use the SABA, when to use sodium. But I've written that. Then I've seen the debate. Then we did a research. Then we came to this conclusion. Okay. So that's exercise-induced asthma. Remember, learn less information, but properly. Not too much, and then you don't know anything. Okay, next one is COPD. Remember, I told you, smoking history, go to COPD straight away. Lung cancer, straight away. All right? So what will they ask you in COPD? It's not the treatment. because it's similar to asthma. They don't care about that. Investigation is spirometry. They just want you to diagnose it, guys. All you have to do is COPD. It's not much. They have to diagnose is COPD. Look at the smoking. If they're coughing, short of breath, is COPD. Now, what they do ask you, and what's very common in the hospital anyway, COPD with a chest infection. Okay, so COPD can get chest infection very easily, because their lungs are already compromised. So most common organism is H. influenza. That comes up in exam. So remember, H. influenza, COPD. Every bacteria should give you a diagnosis straight away in your head. H. influenza, COPD. Okay, and obviously we treat that with amoxicillin Comox. That is, again, depends on the trust that we follow. Okay, there's no specific antibiotic for everything. So for COPD, I'm repeating, we have to diagnose the COPD and we have to know the bacteria that causing the infection, which is H. influenza or strep pneumo as well, actually. But H. influenza are seen in the answers more than strep pneumo. Okay, no confusion. Next one comes up in exam. Allergic bronchopulmonary. Can you open that page, please? Okay. In here, you don't have to learn anything. Key points again. What's the first word? Allergy. What's going to go up? IgE. What's going to go up? Eosinophil. So read the question, eosinophilia, IgE. You don't even need to read the rest. This guy has a chest infection and these two words, go for straight. Allergic bronchopulmonary. Okay, guys? IgE, eosinophilia, and the treatment actually comes up in exam. I don't know if you guys memorize treatment, steroid. Yeah, steroid is the answer. Why steroid? Is you don't even if you don't have to memorize it. It's immune reaction. Steroid will bring it down. That's it. Okay. So remember allergic, IgE, and then you have eosinophilia. Oh, one more thing I forgot. Rust positive. Yeah, rust positive. Don't forget rust positive. Yeah. So can you see every topic? There's few things that you need to know, and then rest is. Next one, cystic fibrosis. Cystic fibrosis is very easy. What problem with cystic fibrosis is, obviously the first thing here, it's autosomal recessive. They ask you straightforward question, what is it? It's an autosomal recessive, and what's the chance? They ask you that, it's 25%. That's an easy question again. It will be a repetitive question. Now, I've seen question people getting, last 2 years question, they're getting it wrong because now they're bringing out new questions. Cystic fibrosis, guys, yeah, if you know what's happening to your body, then you will have a rough idea. You will have thick mucus, okay? So I'm gonna draw this out because I've seen question that is not quite easy. It can. Okay, so look, let's say this is any duct, okay? And they're meant to be a mucus here. This mucus is thick. Why is it thick, by the way? It's because of the chlorine channel. Water doesn't go in. Because of water doesn't go in, you have thick mucus. So think of this. Anywhere in your body that you have mucus, you can get a thick mucus. If anywhere you get a thick mucus, you get a obstruction. Remember that for life, yeah? For medicine purposes, it works all the time, mostly. If there's an obstruction, before that obstruction, there's a high chance of infection, obviously. So anywhere you think of an obstruction, before that you think of infection. So anywhere in your body that you have mucus, you can think of an infection there. So that's your CF. Because CF is not working in one area, it's working in your mucus. Anyway you have mucus, you can have all of the problem. Look, pancreas, duct, present. Fallopian tube, duct, present. Lung, mucus, present. So anyway, all of these. So if you understand the pathophysio, then it's easier to remember CF. CF, I will tell you a few more, but look for CF questions in the last few recalls, because I've seen new questions up. So go through CF questions, okay? I'm telling you. Oh, yeah, there you go. Now, few common things. Obviously, we know for the exam purposes, as far from the old exams, baby will have history of meconium ileus, very common. Recurrent chest infection, I'll tell about bronchiectasis, it will make sense. If you see the word recurrent chest infection, two things should come up in your mind. Yeah, bronchiectasis and CF. Bronchiectasis and CF. Malabsorption, again, because the duct is blocked. You know why malabsorption, right? Pancreatic duct is blocked. So you don't have all the pancreatic juice, all the enzymes, so you have malabsorption. Okay? Investigation comes up in exam, but I'm sure everyone knows sweat test, and that's your CF. Remember, do question on CF. I've seen question, and understand the pathophysio and basic stuff that we've mentioned there. Okay? So malabsorption, failure to thrive. You see the word a lot, failure to thrive in CF. Recurrent chest infection, bronchiectasis. Okay. Now, bronchiectasis has been loads of question in bronchiectasis, isn't it? So whenever you see recurrent chest infection, it should give you a hint that it's bronchiectasis of CF until proven otherwise. Now, bronchiectasis, I'm going to draw a picture. The definition helps. Okay. Permanent dilatation. If you have permanent dilatation, already you can see this is how it should be, and now is this permanent dilatation. Why do you get a permanent dilatation? Because this is the normal guy. Okay, let's say this is the normal guy. He gets chest infection every day, every other week. Because of the recurrent chest infection, it will become this permanent dilatation, wider permanent dilatation. What's the problem? If it's bigger airway, bigger duct, you have more mucus. That's why in your in symptoms you have copious amount of mucus. Okay, so look at the picture. That should always be in your head. This is normal. This is abnormal. Because of all this recurrent infection, it pushes it away, makes it dilated. Okay, so dilated one. What causes bronchiectasis? Obviously CF. Now it makes sense why CF can cause it, because CF, you have recurrent chest infection. And then, okay, another thing comes up in exam here. It says ciliary dyskinetic syndrome. Young patient with ciliary dyskinetic syndrome, they will have bronchiectasis because those cilia is not working and that causes dilatation. Okay, young male. That's those new questions coming up. Okay, in bronchiectasis, you also will have what? Clubbing of the fingers. Write that down. People forget clubbing of the fingers very easily. I memorized, I still have memorized clubbing of the fingers, okay? Now, bronchiectasis question, they want you to diagnose it as bronchiectasis. Second thing, they want you to tell them the most common organism. Most common organism, memorize it guys, H. influenza. Haemophilus influenza. So again, all the bacteria, every time you see them, it should give you the diagnosis behind it. H. influenza is another one is COPD. COPD and then bronchiectasis now. Okay. There are other bacteria, but the most common ones I'm telling you. Now, CT. CT signet ring. Memorize that. CT signet ring. Sometimes they won't give you any of those clues, but they will just say CT signet rings. Okay, and obviously they will give you CT shadow showing widespread tram track, signet wings, those things. Yeah? Now, treatment for bronchiectasis. Obviously, is an infection, what else are you going to give? Antibiotics. But you see in a lot of answers, physiotherapy has been there because of look at what's happening to your. So you need some physio here. Cystic fibrosis, those things, you need physio. Now, if you have abscess, you need to drain that. There's thoracentesis, there's lots of questions. If you do them just properly, you see the answer varies for bronchiectasis. One says antibiotic, then one says physio, another one says chest draining. Read the question properly. What's the problem? Okay, the problem is not the infection that they're worried about. The problem is they're worried about is the abscess. So you need to think of the, if they're thinking of a long-term planning, then you're going to go for physio. Okay, so there's 3 treatments, memorize all of them, understand them. Obviously, because I've explained this, you should make sense anyway. Just use it in the right place. Sorry? Absolutely. Next one is TB. Remember, respiratory is nothing to explain. It's rather, you have to know the key points. You finish rest very quickly. Okay? Okay, TB. Okay, again, I'm trying to give you a picture for everything, so that will hopefully sticks in your head. For asthma, we've done the 3 steps. For bronchiectasis, this is a picture. TB is very easy, but I'll give you a picture. This bacteria is a very dangerous bacteria. What's the problem? This bacteria, we cannot break it. So our body found another solution. Let's say this is the bacteria. We form a wall around it. So our literally white cell, they go and they form wall around the TB. Because we can't break it. We form a wall. And that is, we say, gone focus. Since your medical